Good morning and welcome to today's webinar titled Driving Value-Based Care Success Through Virtual Care Management. My name is Jeanette Wider and I'm Managing Editor of Healthcare Innovation. Today's program is sponsored by TimeDoc Health. Thank you to our sponsor and to our audience for giving us your time and attention today. Before we get started, we have a few housekeeping details. To submit a question, use the Q&A box to the left of your video window at any time. You do not have to wait until the end of the program. For technical issues, please press F5 to refresh. And if that doesn't work, you can submit a question with your issue through the Q&A panel. Finally, join our webinar conversation on Twitter. You can tweet using the hashtag HILiveWebinar. At this time, I'd like to introduce Sarah Cameron, Vice President, Clinical Strategy at TimeDoc Health, and Dr. David Ballard, Chief Executive Officer, Premier Health Associates. So welcome and thank you for joining us today. Why don't we begin by the two of you introducing yourselves. Sarah, why don't you start?
Sure. Thanks, Jeanette. Really excited to be here. Like you said, I lead our clinical strategy here at TimeDoc Health. We are a tech-forward healthcare digital innovation company that really focuses on delivering valuable patient care to patients in their home in partnership with their primary care providers. And Dr. Ballard is one of our esteemed partners, so we're grateful to have him joining us today as well.
Thanks a lot. My name is Dave Ballard, and I'm a managing partner for Premier Health Associates. It's a moderately sized primary care-based multi-specialty practice. We have about 14 locations, 38 providers, grown to about 40 some this year. And it's very nice to have the opportunity to interact with all of you and tell you what we're doing and find out what we're doing right and what we're doing wrong. And Sarah is always a big help in that respect. So appreciate the offer to be here. Thank you.
Great. So we can hop right into the questions I have for you guys today. So Dr. Ballard, this one, maybe you could start off. The days of independent primary care providers are limited, and you've managed to stay relevant. How have you done that?
So healthcare is like regional, right? So, our region tends to have a lot of very big health systems, hospital-based health systems, and that's really what we're competing against. So, when we're setting out, we have options that we have to think through. And, the first option is, how do you compete with a $4 billion health system? Well, you don't try to do it in a fee-for-service world because they get better rates and you're not going to win that game. So we believe that, doing value-based care actually levels the playing field for us, because now all of those big costs that are generating a lot of revenue for a hospital system is actually losing money in the value-based system. And so we chose not to play their game. And by doing that, we've set ourselves up in a position where we can leverage the 50,000 patients that we have to actually save money for the system, improve care, and then have a system where we can share with the revenue that we do share, that we do save the system. So I think by not playing that game, which is let's get bigger, add more stuff, and make more money, and cost everybody more, we've actually positioned ourselves to do very well. And you can tell you're doing very well when the phone starts ringing, right? When people say, hey, what are you doing? And are you for sale or whatever? And so we know we're on the right path for what we're doing. And I certainly see a lot of independent providers now calling me and saying, can we come on board? So I think that's how we did it. We identified the problem and we came up with a solution.
Great.
Yep.
So my next question for the two of you is, adding costs to a patient's overall care through monthly CCM and or RPM seems counterintuitive to a value-based care model. How do you balance the risk of increasing costs with the benefits of chronic care management and remote patient monitoring?
That's a good.
Sarah, you want to start? It doesn't matter to me. I might as well start because I'm talking, right?
Go for it.
So, again, we're looking at what's the end result. The end result is we want to improve people's health care and save money, right? So where's the money spent? Well, it's not spent on a care management fee. It's spent on a wasted emergency room visit, which often ends up with wasted hospitalizations, et cetera, right? So the more we can reach out to our patients, keep an eye on what's actually happening with them, offer them alternatives to expensive based care, we think that that's a winner every time. The patient benefits because they are not having these unnecessary things done to them. The system benefits because we're not wasting tremendous amounts of money. And we all know where the money's wasted. It's emergency room and hospitalizations. So that is where spending some money on care management, remote patient monitoring pays dividends.
Mm-hmm. And Dr. Ballard's right. CCM has shown to decrease beneficiary spend by about $74. So that's about a month and a half of CCM is essentially paying for itself. And then beyond that, as Dr. Ballard alluded to, keeping those patients out of the hospital and out of the emergency room because they're being educated on how to manage their chronic conditions. They have a closer relationship with their primary care provider because they're engaging with a member of that team month over month. And so those patients are going to their primary care provider first instead of going to that hospital. What we also see is increased patient satisfaction for the exact same reason. They feel more connected to their care. They feel more connected to their care team. I think that's one of the most important pieces around CCM and RPM is that providers can't do it alone. They really have to have a team model around them, like Dr. Ballard and Premier has, in that they already had nurses on staff that were working with patients directly, but realized that they wanted to expand the opportunity to engage even more patients in a more effective way. And that's how our partnership has grown over time. We share patients, his team works patients, the Time.Doc Health team supports patients as well. And what we're doing is really providing that holistic care for the patient and ultimately driving those outcomes. Like Dr. Ballard said, it's an investment in the future because once you close those quality gaps and you reduce cost, you're able to partake in some of that shared savings at the end of the performance year.
And I would emphasize that having a team approach is really essential. Like Sarah was telling me earlier, I think she's probably right. To do all this by myself would take 27 hours a day. And obviously I need to sleep 4 or 5, right? So that wouldn't work. So by having a team and the critical part we found, and I'm sure it's different, everything's regional, like I said, is, having the same person as often as possible reaching out, become almost like an extension to the patient's premier health family is very critical. And we always try to do that. Doesn't always work, but that's the model. So that, if it's always the same person reaching out and that patient knows that if Sarah's the person making the call, that Sarah has a direct line to me if there's any questions, that she's going to let me know and I'm going to follow up. So the patient feels more connected to what we're doing and they're less likely to feel isolated. And that isolation causes bad things to happen, like, well, I got a sore throat and it's 10 o'clock at night. What should I do? Where if they knew that they could call us and we would say, you can have a virtual visit now, or we can see you in the office tomorrow. You don't have to go to the emergency room unless you can't breathe or there's something really bad going on. Sometimes just that reach out really affects change. And I always tell people, when you get older, a hospital is kind of the worst place in the world to be. They torture you there, right? You're getting needles stuck in you. You get woke up all night long. It's really not conducive to being healthy. So you have to limit your hospitalizations to when your life is really going to benefit from it. And the patient doesn't know that often, they just think that, well, I've got a sore throat, I should go to the emergency room at 10 o'clock. Might not be the best plan. But by having the extra people to help us with those care plans, it actually affects change. And again, what's the goal of change? Improve quality of lives. And if we do that and we save money, it's a win-win.
Absolutely.
There you go.
Dr. Ballard, I'm curious, as you've been working with us doing remote patient monitoring, would you agree that bringing organized data sets to the providers in your office has allowed them to make more informed, more timely decisions? If we think about hypertension, remote patient monitoring, that to me is also a time saver because you're able to titrate that patient's medications or make treatment plan adjustments a lot sooner and see an improved quality of life for that patient as their health is better managed.
You know,
it seems like that was
blood pressure is one of those things. You know, it's like every hypertensive that comes in my office says the same thing. It's just you that makes my blood pressure go up. I said, well, how do I know it's not your wife or your kids or driving in the car? And the answer is you don't. You know, you don't know if it's just they go in the office and they freak out. And that's why you don't want to be treating people, particularly the elderly. You start treating them with hypertensive medicines, they get dizzy and lightheaded at home because their pressure's 30 points lower to begin with when they're home. So I see that all the time prior to remote patient monitoring. And now I have a tool where I can actually differentiate, is this person really hypertensive or is it just me because I'm a scary guy making the pressure go up, right? So what I see with remote patient monitoring is I get that daily feedback. And I may have somebody in the office all the time who's 150 over 94, which, you know, that's pretty high. And at home, they're 128 over 86. So now I'm saying, well, am I going to treat an 80-year-old with a 128 blood pressure at home? No. But I didn't know that. Prior to that, I might hit them with a pretty big dose of something to bring them down and make them actually sicker. So now I'm spending some money, but I'm getting the feedback that's going to do the ultimate goal. Again, go back to the ultimate goal, improve quality of life, decrease hospitalizations and waste of money, right? So when you have that tool with the care manager with our system, it's a home run, right? And I think that's just an easy way to look at this now. And I get that data every day, it comes through. And sometimes, listen, let's be honest, sometimes it's annoying to get all this data, but it's certainly easier for me to look at a page of data than to have a call that Mrs. Jones is in the emergency room because she passed out, correct? Or she had a stroke because it actually was 180 at home. So it really helps. And my nurses now here, they know we have, the beauty of the system is we set up our parameters. So if some patient, I may say, you know, I don't care that their pulse is 60. Don't call me for that because she's been 60 for the past 30 years. I've taken care of her. But somebody else, I may say, you know what, if their pulse drops down below 60, you need to call me right away. And I can create the parameters that allows me to have you take care of our patient. Home run. Yep. Every time.
And it's very patient-centric. I think that's a good point about the parameters for sure.
Yeah. It's provider-centric because ultimately the provider does understand the person more than anybody. That's why I said I literally now I'm getting old. I get it. But I've been treating people for decades. So I've known these people literally, you know, somebody came in today at 32 years, same lady, you know, and we reminisce about her pneumonia in 1990, you know. But the thing is, now she's got chronic conditions, and these chronic conditions, your life changes. But I know her, and I know that if I lower her pressure too much, she's going to be just calling me every day and not feeling well. So we came up with a plan. Let's keep it, you know, 130-ish, you know, and I know I'm getting a benefit because she'll take her pills. That's the other thing, you know. You can do anything that a guideline tells you, but if the person doesn't do it and I have no way to know they're doing it, then nothing really has happened, but I feel good when I go home at night, but I haven't accomplished the thing. With the data, I can say, hey, you're 180. You're not taking your pills. Don't tell me you are. And she'll say, man, no, I wasn't taking them. Okay, let's have a talk about that, right? Data always helps. If it's data that you actually want and you can utilize and you think about. Remote patient monitoring, chronic care monitoring is a home run, as I said before. Thank you.
Okay. My next question is currently federally qualified health centers, FQHCs, are not reimbursed for remote patient monitoring. How can FQHCs still leverage the benefits of the technology without reimbursement?
Sure. I'll take that one. So Dr. Ballard is obviously an independent medical group, not an FQHC, but I think he's going to have some good insight here. So a lot of our clients here at TimeDoc are FQHCs or RHCs, and RPM is not currently reimbursable for FQHCs or RHCs. I think it's a health equity challenge, given that those FQHCs and RHCs are really designed to serve the most underserved populations in our country. Giving them access to RPM and other technology tools to enable providers, as Dr. Ballard just described, to better care for their patients seems like a no-brainer. So a lot of our partners have been trying to find creative ways. And one way they do it is they start with CCM. They start with CCM, and they leverage CCM paired with RPM to help fund some of the costs related to remote patient monitoring. We also have helped our clients navigate how to leverage grant funding that they have. So some of them will leverage grant funding, but the challenge with grant funding is that it's time-based and it doesn't last forever. And so what a lot of our clients have done is leverage grant funding for program startup costs related to device purchasing, et cetera. And then they'll leverage that CCM monthly reimbursement to continue the program going so that they can continue to provide it, because it becomes too valuable to their providers and to their patients to stop it once the grant funding runs out. And even though Premier is not an FQHC or an RHC, they followed a similar model, launching CCM first and then adding on RPM later on after we had worked together for a bit. Dr. Ballard, I don't know if you want to add anything to that and how that worked for Premier.
Yeah, well, I think like everything, I'm basically conservative, so baby steps, right? So let's see how we do with chronic care management. Seem to work pretty good. Let's expand that. I would say to people who find that it's not paid for, you have to go back again to what I always say. What are you in business to do? If it's just to make money, then it might not be the best thing for you. If it's to improve the quality of care, then it's still a value. Okay, so if we could use care management to help offset some of the costs, that's great. If you're in any kind of shared savings arrangement or where we're trying to head to full risk, well then, you go back to, if I can keep one stroke from happening a year, I paid for RPM for the entire practice for 6 months or a year. So, we always have ways, if we're adding value, to find the money to pay for something like that, and like I said, the RPM has a lot of value. And you don't realize how much value until you start using it, because prior to that, we were guessing. They were educated guesses, but they were guesses nonetheless. We were guessing at what people's lives were really like at home. But now we have data to tell us what their lives are like at home. And there's a difference. Educated guesses are great. It's what I do for a living, but educated guess with data is always better.
Absolutely.
If that, yeah. That'd be my
Dr.
opinion.
Ballard, would you say that the data in and of itself gets you all the way there? I think you'd agree that it's the data plus that human component, and not just the provider human component.
Yeah. There's three pieces. There's the data. Well, there's more than three pieces. The data, where you're getting the data, who's collecting the data, and is that person going to help us establish the connection that we need to make sure we can act on that data? And that's where the care managers are always critical, right? Mm-hmm. Because a lot of times you'll be interacting through me on what I want you to do and tell the person. And if the person doesn't know who you are or trust who you are or care who you are or answer the phone when you call, it doesn't work. So there's always a piece of personal interaction that I think makes us more successful than other thing. Particularly, again, I'll get back to our original premise. Hospital, big billion-dollar thing, right? Big building, not a lot of personality going out of that thing, not a lot of personal touch. People like to still be talked to and know about their sisters and brothers and cousins, and that kind of business is something that you can't just create because you have a boardroom that's ivory, right? So I think it's critical that we keep that touch, even moving forward in this crazy world we're in. And the remote patient and chronic care help us do that, which is what they should do to assist us. Okay.
Yep. Agreed.
Okay. So there's so many initiatives that organizations can implement to, be successful in accountable care organizations. Annual wellness visits, TCM, care coordination, improved risk, acuity coding, etc. How do you recommend prioritizing all of these things?
Yeah. Well, they all kind of fall into the same bale. So if you say to your organization, we're gonna be a high cost, high revenue business, you don't care as much. If you're doing high cost surgery and running 10 CAT scans, it's not as critical. And people will yell at me for saying that, but that's just my opinion, and I'm entitled to it, right? But in terms of if I'm going to do a value-based business, then I'm going to start with value-based products, and value-based products tend to be full risk contracts or ACOs, patient-centered medical home. So if you're in that business of taking care of people, then you say, what's the optimum way for us to do that? And it starts with understanding where the costs are, hospitals, high cost specialists, specialty care, right? And then how do we address limiting that to when it's really proper and needed? And that's where all of those letter salads that you said come into hand. And that would be, we start at the beginning, which is an annual wellness exam, right? An annual wellness exam is critical to a lot of our programs. It's critical because it does things that allow us to be effective in keeping our costs down and keeping our care up. The first thing it does is it allots time with our providers so that we can actually see how things are going from a person's healthcare point of view, because there's an extra time allotment for an annual wellness. That can be on the phone, it can be in person, but it gives us the time. What do we do at the time? Well, in our group, first thing we do is we try to assess how sick the person is, because that's critical with any kind of program you have. And I use the example all the time, and people seem to like it. You can be a diabetic who's diet controlled, or you could be a blind diabetic with kidney failure and have lost a foot. Which one is going to be sicker? You don't have to be a physician to know which one's going to be sicker and which one's going to cost more money. In the old system, it was the exact same code we sent to the insurance company for both of those people. Diabetes, L10 or whatever it was, doesn't matter what the name of the salad is. But what matters is allowing the system to know how sick a person is, allows them to allocate the proper revenue to that person, okay? So that's critical for any success in a business. If we're gonna spend $10,000 on you to keep you healthy, but we're only allocated $8,000, we're gonna lose. If we're allocated $12,000, we're gonna win. And so are you, because you're gonna get the same health care either way. We're gonna treat you exactly the same as what you think you should, but at least we know now what it's gonna cost, and so does the payer. So starting the whole system, knowing the game you're in, that's number one. Number two is, what things do we need to do to keep you healthy? Well, now we have time to look at all of those things. How is your mammography? How is your colonoscopy? Do you need the touch of a CCM? Do you need the touch of a remote patient monitor? Do you need my nurse just to make sure you're okay once every 2 months and bring you in? We can start assessing that in this annual wellness visit. So it's a critical piece of the puzzle. And then we always make sure that your immunizations are up to date, or at least we have the discussion. Listen, everybody knows the same thing. Everyone's a scientist now, and they all know more about immunizations than I do, right? I've only done this for 40 years now. But, I have that conversation every day, and what vaccine should you have, and why should you have it? And yeah, I know that somebody's cousin, their foot fell off when they got a COVID vaccine or whatever happened. But in general, we try to follow the science and educate people. And time is the key. And the annual wellness exam gives us the time. And that sets up the whole table for everything we're doing. And we have some partners who help us with that. The other companies that actually assist us with some of this value-based care, and they identify those people for us, and it's a good system. Things like transitional care, care coordination, that all flows from the annual wellness exams. So When I'm seeing somebody who I've seen for a decade and I realize they're starting to get older, I might have the conversation. You're seeing 3 specialists now, correct? Yeah, and they're changing your meds all the time. I need to know what they're doing, because the cardiologist isn't always talking to the nephrologist, isn't talking to the hematologist. So somebody has to know what's happening with all of your people. So I'm going to have you go into our care management program, because right now you're getting to the point in your life where there's too many different things happening that I can't follow it by seeing you every 3 months or even monthly. So what you're going to do is have a call with our care management people after you see every specialist, so I know what they're doing to you, so I can make sure it's okay. And just by having that set up, I know if I do that 10 times, I'm going to save 1 hospitalization, because somebody's going to take 2 different blood pressure pills, not know which one to take, stop all of them, and have a stroke or god-awful thing. So we're going to actually affect those changes by having the annual wellness set up before we can have the discussion. We'll also set up at that time to talk about end-of-life care if it's appropriate. And then we have the big talk is if somebody's been, hospitalized, we bring them back in after they've had their wellness. We want to adjust and update their risk scores. But we also want to look at, okay, what did the hospital do to you? And was it a good idea? And should we revert back or listen to them? And there's many times, a person's dehydrated, sick, and septic. So obviously their blood pressure's low, right? They have no fluid in their system. So then the blood pressure pills were stopped, and then they're sent home, and now they're hydrated and their pressure's through the roof. So they're actually at risk. So now by bringing them in and addressing those things, that's called a transitional care visit after hospitalization. I think it's critical for what we're doing, because it prevents the real craziness of healthcare, which is the change everything, confuse the patient, they stop taking all the pills and get readmitted to the hospital. We have data that suggests for every 7 people we take in and go over what happened to them in the hospital with a prolonged visit, get them into care management if they need it, resume care management if they don't have the visiting nurse. For every 7 of those, we save 1 readmission. Now, if you know the cost of a hospital admission, if you do that, 1 out of every 7, you've just made your annual shared savings. That easy. How's that? I make it sound okay, right?
Super easy, right?
And then you need a stick to hit all your doctors on the head to make them do it. We'll have another thing about that. Another webinar, how to beat your providers into submission. I'm kidding, of course. Joke.
Of course. Provider engagement is key across all these, across the word salad, as you like to call it.
Sure.
From my perspective, and I, in a past life, ran care management for a market within an ACO. And one of the biggest challenges for providers that were starting new entrants to ACOs was figuring out where to start. And not only where to start, but how to resource those endeavors, because all of these things that Dr. Ballard just explained require both capital investment as well as human investment, meaning the bandwidth of your current staff or hiring people to take on some of these initiatives. And by instilling care coordination, either through CCM, RPM, it really starts to alleviate some of the day-to-day workload that are on providers and in-office staff. So care coordinators are fielding the calls, like Dr. Ballard said. They're following up with the patients to make sure that they're scheduling their appointments, they're going to see their specialists, following up on referrals. They're doing those things so that the people in the office can start thinking about and implementing some of these strategies to be successful in a value-based payment model. And from there, as you start getting into CCM and RPM, there's some of that revenue that comes in as well. And you can invest in risk acuity coding training or an actual coder to come in and help your practice be successful in that regard. I think that one of the biggest challenges for folks or providers that have not been in value-based payment models historically, there's a barrier to entry based on that investment that's required. And that window to get into ACOs is really starting to close. Medicare has come out publicly and said that they want to see all Medicare fee-for-service patients in a value-based arrangement by 2030. And we saw that as this year in the FQHC space and the RHC space, the number of ACO R.E.A.C.H participants increased dramatically. Even within our own cohort of clients at TimeDoc, we saw a lot of our clients going into ACOs for the first time. And, as you get your feet wet, so to speak, and start to map out all of these things that you can do to be successful in those value-based care contracts, you're investing in the future. Like Dr. Ballard said, as you move into full risk, that's where the financial independence, I guess we could call it, for Dr. Ballard and Premier in being able to continue to operate as an independent group.
Yeah. We're a smaller group, but we're not tiny. And even when we were going into value-based care and chronic care management, I think that one of the things that led us towards your model of partnership was the fact that we could tailor how much we needed from you and how much we could self do, or whatever the word would be. So initially we started with you guys doing a little more work, then we took a little bit back as we ramped up our own care management department, and we've had these meetings now where we're going back and forth and how we're going to do this in the future. But we had the ability to grow the business, and I think for a smaller group, if you're 3-4 guys, it's very hard to say I'm going to hire 2 care managers and hope to have some patients signed up. So having a system where you can partner with somebody, they have the care managers, and then if you want to kind of ramp up your own department, which we do, then you have the ability to do that because you have a revenue stream, and you do need some money. And again, I would say this again, the money we're spending on care management for the entire year is probably 10 hospitalizations. So if we cut the 10 hospitalizations out, unnecessary ones, of course, we're going to be fine and ahead of fine because the revenue's coming to us and not to the hospital. Not that I don't like hospitals, they're necessary. They're just gluttony at times.
Okay.
I guess I'm opinionated. What can I tell you?
So you mentioned that investing in new revenue streams like chronic care management and remote patient monitoring is key to successfully transitioning into value-based care arrangements. What is the exact overlap between the clinical quality measures and outcomes that are the focus of chronic care management and RPM fee-for-service programs and value-based care arrangements like the ACO R.E.A.C.H? It's a loaded question, I know.
I can do that one to Sarah because I couldn't even follow that question.
I can start with that one. Yeah. So, Dr. Ballard's talked a lot about reducing cost, right? Keeping patients out of the hospital, out of the emergency room, choosing more affordable sites of care, et cetera. You can do all that, but if you don't meet your quality metrics, surrounding preventative care, A1C control, depending on, the type of arrangement you're in, if you're not actually improving that quality of care for those patients and their outcomes and reducing costs, you can reduce cost all you want, but you're not going to see any of that shared savings. And so CCM and RPM and virtual care coordination in general, really the goal and the way TimeDoc has looked at it pretty much from the beginning is how do we drive outcomes for our patients? It's not a monthly, hey, how you doing? Got all your meds? Did you fall? Did you go to the emergency room? No. Okay, great. Talk to you next month and then build patient. Really the goal is to walk that journey with the patient and say, oh, I see you're due for your colorectal cancer screening next month. Do you have an appointment scheduled here? I see Dr. Ballard put an order in for you. Oh, no, I'm not going to go. I'm not going to do that. I don't want to do that. Well, tell me why. Gather a little bit more information from the patient and feed that back to Dr. Ballard so that he can have that shared decision-making conversation with the patient when they're in the office next. Because if you don't close those gaps, like I said, you're not going to realize any of that savings. And so really it's about generating that education for the patient, for something that a provider, they can do when they see the patient, but it's not something that they can necessarily spend the time to do. So it's reinforcing the provider's message between those visits. It's making sure that the patient understands the value in the preventative care and making sure that they're closing those gaps. And then 3, making sure they're getting it done. We know that patients have barriers to accessing care. Depending on where they live, it could be transportation, it could be availability of the service, it could be just fear of going to have a new procedure done that they've never had done before. And so care coordination programs are really adept at digging in and finding out what motivates the patient, what's going to drive them to follow their treatment plan as designed by their provider to make sure that they do stay healthy. And sometimes it's that little additional bit of education or that reinforcement from something they just heard from their provider at their last office visit coming directly from their care coordinator can really get patients over the line. Late last year, we ran a pilot with a group of patients in our CCM program who had open colorectal cancer gaps. So they had outstanding orders, they had not closed, they had not gone to get them, et cetera. Within about 30 days, we had 70% of those patients either had completed FIT tests, had ordered the FIT tests, or had colonoscopies scheduled and or completed. And so just that little extra reminder, that little extra bump, it was very low effort on the care coordinator's part, as they were going to be speaking with the patient anyway. And it just took that much of a nudge to get those patients over the line and close a significant amount of gaps or put a significant amount of gaps in process of closing in a really short period of time. And all of that was reimbursable through CCM.
That's good use of a team, all working for the same goals, I think.
Yeah.
And that would start at the annual wellness exam and move itself through the system. You could tell somebody to do colonoscopy. You might have to tell some people 5 times before they'll do it. And then after they'll do it, they invariably say, why didn't I do that 2 years ago when you told me the first time? I say, I know. That's how life is. I'm just stubborn, so I kept at it. All right.
Great.
I like that.
Great. So my last question for you today, before we jump into the audience questions, is the quadruple aim can often seem unattainable. How do outsourced care coordination programs and technology make the quadruple aim more achievable?
So just to level set, the quadruple aim, more traditionally has been known as the triple aim. So if we think about the quadruple aim, it's improving quality, reducing cost, and then improving both provider and patient satisfaction. And so when we look, if we think about this conversation we've just had over the last 30 minutes or so, we've touched on each of those pieces in how these care coordination programs, that team-based approach to care, alleviates some of the burden on the provider. It provides a more continuous and continuous touch points for patients, creating a more patient-centric approach. They have someone they can talk to. They have someone they can problem solve with. A lot of patients say, I don't want to call and bother my doctor. I know that they're busy. I don't want to bother them. That's what their care coordinator's for, is to field those questions. Say, let me get in touch with Dr. Ballard about that. I'll get back to you. That's really the driver behind those patient satisfaction scores, which are also really important in value-based payment models. And then increasing quality and reducing costs goes hand in hand with seeing some of those results of the investments that you make when you move into a value-based payment model.
Yeah, I would agree with all of that. One of the advantages we have, our physicians tend to be more satisfied because they feel they have a little more control in their system. And I think a lot of provider dissatisfaction is really is some big brother or sister that's controlling everything about their job at this point. And many of them didn't go to school that way. They went to school to help people understand how they got in a position where they're 9 to 5ing with somebody telling them when they can go home or take a lunch, and it's not really how providers think in general. So I think having a system where you can maintain some of that independence, and have a feel like you're steering your own ship to an extent is very valuable. And to the extent that, risk-based care or value-based care allows our providers to really do very well and know that they're doing a good job and that the patients are happy, it all kind of fits into the one big salad that we're trying to create here, which is, at the end of the day, I'll say it again, we want to improve the quality of people's lives. When we do that, there's an innate satisfaction with what we do for a living. And when we do that, and we do that in a way that we control it more and we can pay our bills easier, then it's a win-win for the provider. So I'll add, my piece is the fourth piece of the, what did you call it? Quadruple? Whatever, yeah. So,
Quadruple aim.
Yeah, the quadruple aim for me is, I know the first 3 we're going to do, and the benefit of all that at the end is I've made the providers happy. Like, people don't leave here because they know they got a good thing,
Yeah.
And that's how it works. So I appreciate it. You guys are
And I
helping.
can validate that. I had the opportunity about a month and a half ago to visit a couple of premier sites, and we knew not all of our providers were on board in the very beginning, which is typical with a lot of our clients, and they're kind of unsure of something new coming in, and I had the opportunity to speak with some of them, and they were just over the moon, just super excited and asking questions. And what if we did it this way? How could we do this? Being really strong partners in ensuring that the program and the patients that we share are getting the best care possible. And so seeing that excitement and that collaboration come from the providers that were late adopters, we'll call them, it was really great to see. And I think Dr. Bollard's done a great job of being a physician champion for this as well, which is so important, because the last thing you want to do is lose that fourth piece of the quadruple aim and not have your providers be happy.
Happy provider, happy practice, right? Listen, here's what I thought about that. It's an interesting thing that we have these great providers, and everybody's getting beaten up in healthcare. I mean, it's just how it is, right? And our IT system, I love the guys. They would come up with something, say, hey, we got this great thing, and it's only 5 clicks, people a day. So it's really 150 clicks. And I work 5 days a week, so it's really 750 clicks. And I'm working 48 weeks a year, so it's really, so you just added me going click, 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 click. You added like an hour of me doing this. How can you improve the quality of my life when you do that to me, right? And that's kind of how providers feel throughout the day. And people who don't do it don't get it, but I get it because I do it. And so when I can find something where you can say, put them on CCM, have them call me, I don't have to click 1,000 times, I've actually made our providers' lives better, and I've made our patients healthier. So again, I got a win-win. And I might have some revenue coming into the group that I'm taking out of the hospital. So I got a win-win-win-win. So there you go. That's my life. I love it.
So we've already had some questions coming from the audience. However, we would also like to remind you to use the Q&A box to the left of your video window at any time. So let me pull these up.
If they're nasty, I don't want to deal with them.
Everybody is, no way.
It's a joke. I'm a joke.
The first question is a good one. The alignment between CCM and RPM and lower costs and better outcomes seems clear, but how do your providers find the time to engage in these efforts?
Well, I mean, what do we need to do here? We need the annual wellness exam to provide the time to identify where the gaps are. And if one of the gaps are that we need this person to be seeing more touches, well, the annual wellness. The other area is the ancillary providers. So nurse practitioners, PAs, et cetera. I mean, they're highly qualified, but you need to use people in the proper place. We found that a complex hospitalization transition to care patient is probably not the best place for a nurse practitioner, but an annual wellness exam is an ideal place, because just the nursing background, there's a communication factor that just has the right way to approach patients, and then identifying the gaps with the provider about would this person be a good CCM, and then Dr. Casella or somebody would say, damn, why didn't I think of that? That's right. So you have to find the places. It's not in the 29th visit of a 35 visit day when you're a half hour behind and somebody has 4 problems that they came in with. That you'll always feel the pressure. When you design your schedule to have assistance, and you also design your schedule to have the proper places to address those things, and that's where they naturally fall. And I would say ancillary providers and annual wellness exams are 2 ideal places for that. I hope that answers that question. A little wordy, but I'm getting tired.
I would add too that, finding a partner, if you do, choose to leverage a partnership like an organization with an organization like TimeDoc, find one that's willing to work with you and really is an expert in implementation. I think we've found really great success when we have solid project champions. To give a shout out to Paula and Dr. Ballard's team.
Could I say something about that?
Yeah.
I'm sorry to be chatty, but AI helps, right? Artificial intelligence. Like you guys have the ability to actually go into our database and identify people who may be higher risk, right? Very beneficial. We have several different partnerships that are like that we leverage some AI to identify people who may benefit from certain things. So that's a third way, and I should have said that initially, and I apologize, because we do that all the time. We do that with some of our research-based medicine all the time.
I think that fits right in, leveraging technology to the extent that you can, so that you can ensure that not only your providers have the time to do these things, but really build a program that fits into your existing workflows. That's one of the primary reasons I think TimeDoc has been so successful in this space, is that we are also doing it. We are also operationalizing CCM and RPM with our own clinical staff. And so we're able to provide our learnings to partners like Premier that are also doing it in partnership with us. So they're not starting from scratch. And we can help them kind of get over some of those early learnings, and they don't even have to have them because we're showing them what has worked best historically. So I think that's also part of it, is developing a program that fits right in with a provider's workflow and ensuring you're setting up communication pathways between the teams, the care coordinator, the RPM data, giving it to a provider as actionable. These are the averages for the last 30 days. These are the individual readings, so that they can look at the individual readings if they want, or they can just see the average at a quick glance when they're walking into a room with a patient. I think that's one of the most valuable things, is fitting in these activities into a provider's daily workflow.
Yep.
The next question I have is, do you have care coordinators triaging patients for you?
Yes. So post-hospitalization, post-ER, we get the data from some of our partners who was in the emergency room, who was just discharged from the hospital, and it'll be a combined effort between our MAs and our care managers to reach out to those people within a very timely 48 hours for emergency room, 7 days, maximum for a hospital, to get them into the office. or at least have a touch. Now, some of the people to there for sore throat, they might not need to come to the office, might just be, you know, next time you can come to see us. But somebody who is critically ill, we're going to get them in. And the care managers do that all the time for us. They reach out.
And in terms of RPM, so for our programs, we co-manage these patients with the Premier Care Management team, but for our other clients that are that we're caring for their patients entirely, we do triage those critical alerts as they come in. So we respond to them, call the patient, see if they're symptomatic. If they're symptomatic, we obviously get them engaged with emergency care. But what we're doing is we're capturing the information. We're trying to figure out what happened. Why are they having a critical high or critical low blood pressure, pulse, and then finding out what's changed and then communicating that information back to the provider so that the provider can make a decision. Do they need to see the patient? Do they do a telehealth visit? Do they make some med titration changes once they've had that visit, et cetera? So that's how our team functions in the triage space with remote patient monitoring.
The next question is it better to layer RPM onto an existing CCM program or the other way around?
I guess it depends what you already have. I would, from my perspective, we typically start with CCM because it's a wider net and the workflows are similar. There are going to be just naturally more patients eligible for CCM than there are for RPM. We have launched CCM and RPM simultaneously, and that's also worked. But I don't think you can go wrong either way. I think the key is having the same person engaging with the patient for both programs. So having the same care coordinator. We actually have higher engagement with patients that are in both CCM and RPM and better outcomes than those that are just in remote patient monitoring. And so combining the two, I think no matter which way it goes, can be beneficial for your patients. And it really depends on what is right for your organization, how things are going, and ensuring that the CCM and RPM programs will work together. I think as long as they work together, whether you have CCM already established or RPM already established, you can easily layer on one or the other.
Let's look at the next question. Do you anticipate that RPM reimbursement?
So, depends on what.
Oh, I'm sorry. I think you're a little frozen there, Dr. Ballard. Did I cut you off? Your face is frozen. Oh no. Did we lose him, do you think, Sarah?
Uh-oh.
Uh-oh.
Am I still frozen?
Oh, no. I can see you now. Okay, no, we can see you now. You can go ahead.
We made it this far.
I touched nothing. I touched nothing. Yeah. So close. Yeah. 8 minutes. Never mind. I'll just stop. Let's go to the next one.
Okay, I apologize. I would never cut you off, Dr. Ballard, on purpose. You were frozen you had a cool hand gesture there too.
Felt like I was home. Felt like I was at my house.
Oh.
Hey, I got a quick joke for you. So people say, you're getting older. Why you keep doing this? And I'm saying, well, when I'm here, I can say to you, you go get me this, you get this person on the phone, you do this for me, and people run all over the place, right? When I'm home, if I say, like, give me a glass of water, my wife and daughter will look at each other, laugh, and walk away. They're like, yeah, get your own. So I'm like, which line do I want to be on? I don't know. It's a tough decision, right? Think about it, right? That's how I maintain my validity of life, I guess.
So our next question is,
digress.
do you anticipate that RPM reimbursement will continue to decline like it has over the past couple of years, or will it stabilize and or increase?
It's hard to know.
I make no decisions on what things are going to cost in the future. I look at the value of the whole system, right? And this is why heading towards full risk is the critical part of this, because otherwise we're playing the stupid game of, I want to make another $1 per person or whatever the hell it is. We want to save thousands per person, while improving their quality. And if we do that, and RPM allows us to do that, we're well ahead of the game. And it is a silly healthcare game, unfortunately. So if we can do it that way, I don't really care what the price is going to be. If there's a value to it, we're going to do it. Right now, it's a value, and we're making money on it. So yeah, but even if I was losing money, I know the value of it, and we would probably be as selective as we are now with who we use, because we get a value. And when people get a value, it works.
Yep.
I just got a 5-minute.
So did I, and I lost the camera. Now I can't see you guys.
On the top, you can click the top tab right on the top. You can go back.
Ah, there we go.
So in the meantime, I'll ask one of our last questions here that we'll be able to get through today. There were a lot coming in from the audience. So
maybe we should be quick.
Do you feel CCM and remote monitoring has helped or can help reduce provider burnout?
I certainly do. I think if it's implemented the right way, I think having a non-provider program champion, especially at the outset, is really important. And the reason I say non-provider, it would be someone who is either not seeing patients all day, every day, and they have time to dedicate to educating their internal team. They have time to dedicate to working with, if it's an external team as well. I think that that's really important. Dr. Ballard has had a great program champion, Paula, that has been really instrumental in rolling this out effectively. And I think if you don't roll it out effectively and intentionally, getting provider feedback as you're doing it and building that provider engagement, you can contribute to burnout because they're left out of the conversation. I think it all depends on how you implement the program and continue to iterate on it. We really adhere to the model, design, test, iterate, so that we can really understand what's working well for each provider and each practice to ensure that it's a value add to the providers as well as the patients.
Okay.
Can you guys hear me? Because my camera's dropped.
Yeah, I can hear you.
Can you see me?
Oh, not anymore.
Yeah, my camera dropped. I don't know why I can't get back, but I can still talk.
Okay, we can hear you.
All right. Give me another question.
Okay, any tips on how to optimize patient engagement in a CCM program, specifically for those patients who are not as responsive to care manager check-ins?
Yeah, that has to come from the person they have the most trust in, which is usually their primary care doctor.
Yep. Provider, and I think,
if they don't hear from the primary care doctor on this, and they're skeptical or don't see the value, and you do see the value, that you're the best person to tell them why they need to do this. And many people, and I used the example before, the 3 or 4 doctors and medicines are getting changed, said, I need to know what's going on. And the way I need to have that done is by you talking to my care manager. And she's going to report directly to me. And they're like, okay, I'll do it that way. And then sometimes we, if there's still some reluctance, we say, look, let's try a couple months, see if we can add some value to what we're doing with you. And after 3 months, if we don't see the value, or 4 months, then, all right, we'll stop. I mean, it's really about adding value to how we're taking care of you. And that works as well. It's, let's have a conversation. This is my idea. That's your idea. How about we meet somewhere in the middle and see if it works? And if we can't bring value, then we probably shouldn't do it anyway. So we need to add value to the patient's lives. And that's where I think a lot of them decide there is value. Some decide there isn't. It's like a bucket with a hole in the bottom. We pour patients in the top to try to help them. Some drains out the bottom.
Okay, well, unfortunately, that's all the time we have for today. I would like to thank Sarah and Dr. Ballard for today's excellent webinar. I would also like to thank Time.Health for making today's program possible. Finally, I want to thank everyone in our audience for joining us. We hope you'll join us in the future for another healthcare innovation webinar. This concludes today's presentation.
Thanks, Jeanette. It was great. Thanks, Dr. Ballard.
yeah, if anybody needs to reach out to me, somebody can let them know. I'd be happy to answer any questions.
Yep. Same with me.
Okay.
Absolutely. Thanks again.
Thank you. Thank you, guys. Have a good day.